Thank you, Chairman Wyden and Ranking Member Crapo, for calling this hearing and giving me the opportunity to testify. The August 2022 Reconciliation Bill made significant changes to healthcare law, and it sought to address several legitimate flaws within American healthcare. Unfortunately, to do so, the law embraced superficial fixes. This has resulted in an expensive Affordable Care Act sugar high, induced a likely illegal taxpayer bailout of Medicare Part D plans, and will undermine the quality and value of healthcare in the long run. As of 2021, the non-group insurance market had around half the number of enrollees expected when the ACA was passed, at a much higher cost than the authors had intended. Implicitly acknowledging these shortcomings, the American Rescue Plan included a supposedly temporary measure to improve the enrollment side of this equation by simply increasing the taxpayer subsidies that go to insurance companies. The IRA doubled down on this policy while hiding the true cost, again making it temporary. Over 10 years, CBO projects this change would increase federal ACA spending by $415 billion. More disturbing than the enormous costs, these changes simply paper over the poor quality of the plans themselves. A new Paragon Health Institute paper assessed the change in value of ACA plans, looking at three key metrics: the broadness of networks, the associated cost sharing, and premiums. All have steadily become worse over time. New enrollment has been driven by people that, under the IRA enhancements, now pay $0 in premium for a standard plan. Over half of enrollees in some states fall into this category. Many of these previously did not perceive value in enrolling in a typical $500 per month plan, even if $470 of it was paid for by the government due to already generous subsidies. Instead of trying to increase the underlying value, the IRA simply gives away the same plans completely paid for by the taxpayer. In fact, almost no one is willing to pay the full cost of an ACA plan these days without a government subsidy. When the government pays plans instead of people, insurers have less incentive to design plans that potential enrollees actually find valuable. Government regulators attempt to mandate quality, but the result is over time the ACA market has looked more and more like Medicaid managed care. The large increase in fully subsidized plans, combined with the embedded financial rewards for misstating income because recapture of erroneous subsidies is limited by statute, and a relaxation of eligibility verification have all helped increase enrollment, but only through tolerance of substantial fraud. My Paragon colleagues have estimated as many as 5 million current enrollees for whom taxpayers spent $20 billion in subsidies could be over or underestimating their income to obtain higher assistance than the law permits. Perhaps even more highly touted is the IRA's price controls on prescription drugs. Medicare absolutely should and could get more value for many prescription drugs. My written testimony provides recommendations on how Congress could do so. But we know that price controls have enormous consequences, some intended but many not, in determining how resources are allocated, how care is delivered, and where future innovation flows by determining which good or service is preferred over alternatives. So far, the IRA drug provisions are an example of unintended consequences. 80% of the discounts announced last month had previously been achieved by private plans negotiating without price controls. And before any potential savings kick in, they are already being spent by the administration to bail out another flawed provision in the law. The IRA rewrote a previously bipartisan idea, capping out-of-pocket expenditures in Part D, to do so in a way that guaranteed a large increase in premiums. The administration has responded with a so-called demonstration project that simply pays Part D plans at least $5 billion to keep premiums lower. Finally, one of the most perplexing changes in the IRA is the insulin provision. Far from holding drug companies accountable, incumbent insulin manufacturers benefit from and strongly support copay caps. This is why the Trump administration created a demonstration to give all Medicare beneficiaries the option of a plan with a $35 copay cap, but required manufacturers who participated to also provide larger discounts on insulin. The IRA disbanded this program and replaced it with a copay cap paid for by higher premiums for beneficiaries and higher subsidies from taxpayers. It's hard to see who benefits from that change other than the manufacturers. Thank you again for this opportunity. My written testimony includes several modest recommendations on how to improve these programs without so many unintended consequences, which I hope to get to during questions.